and post the slides as we generally do. And I'm going to start out by sharing a set of, whoops, wrong one. Sharing a set of slides to walk us through some information, but we're going to leave plenty of time for questions as well. And feel free to use the chat function for that as well. And as I've said to several of my colleagues here who are co-hosts, feel free to just keep letting people in as folks join. So I am excited to introduce when he's able to be here. Steve, do you see Isaac?
Yeah, Isaac's there.
Yeah, great. Isaac Benowitz, who is our new physician epidemiologist with Maine CDC. Isaac, do you want to say hello first to the group? Actually, I'm going to stop sharing so that they can see you.
Thanks, Lisa. Hi, everyone. I'm Isaac Benowitz. I'm the new state epidemiologist at Maine CDC, taking over the role that Siri Bennett was in and that Stephen Sears was in a number of years earlier. So I'll maybe make it pretty brief, but I've been with US CDC for the last 5 years, working on healthcare associated infection work, and I'm originally a pediatrician by training, and just excited to be here working with all of you, and look forward to connecting with many of you over time.
Great, thank you. Okay, so I'm going to go back to a few slides here, and we'll be sort of changing around who's talking about various topics. But yeah, I wanted to touch base on some of the recent updates about boosters, fourth dose for immunocompromised, timing of vaccine around infection. That keeps coming in as a question. I certainly get a lot of questions about it. I suspect you all may as well. Timing after monoclonal therapies, the big new exciting news about vaccine for children, just a plug again for COVID with Fluvoxamine, and then again, making time to talk a bit more about monoclonal antibody therapies and then some of the new oral medications as well. So with that, I'm going to turn it to Dr. Sears to just give us a quick highlight on some of the changes.
Great, thank you, Lisa. And you've highlighted some of the changes. I think we've all heard these, but it's really, I think, helpful to put them all together. But we know that all 3 vaccines have been authorized for boosters. The only difference to, I think we know is that it's any time after 2 months for J&J, anytime after 6 months for the mRNA vaccines. Who are the boosters most appropriate for? The listing that ACIP provided and CDC then put out is anybody 65 years or older. Essentially, what they did is they looked and said, who are we seeing potential waning immunity, or is there any chance we can decrease breakthrough infections? And they looked, and clearly in long-term care settings, we've been seeing more breakthrough infections, people with underlying medical conditions, and those over 65. They also put in the category of those in high-risk settings. That includes healthcare workers, gets into that group. Again, J&J 2 months afterwards, but Moderna 6 months after the last dose. And the other thing that they authorized is what is called mix and match, which is that you can get a booster with any of the vaccines after different vaccines. They can be, you could get if you had Pfizer originally, you could get Moderna. The recommendation is still to try to use the same dosing product overall, but this clearly gives the ability to do that, which is very helpful. And there's some interesting data on whether mRNA vaccines after J&J are a really effective way to go. The small studies suggest that. Prior to the boosters, we also heard about third dosing of mRNAs, and it's important to try to keep that terminology straight, which is the third dose for moderately or severely immunocompromised individuals was 28 days after the second dose. This was really making a 3-dose series considered to be the standard for severely immunocompromised individuals. And then recently, in the conversations about the booster, it is also appropriate to consider a booster for these same individuals. In this case, it's going to be 6 months after the third dose overall. So that, again, reflecting the fact that people who are severely immunocompromised do not necessarily mount effective responses, and this is trying to get them to that point. There is no clear guidance yet on the recommendations for additional doses for those who receive J&J, but I suspect we'll actually see that. As you said, Lisa, this is probably one of the two big topics, and I'll sort of take this one first and then talk a little bit about is vaccine immunity better than natural immunity? That's the other, it's kind of wrapped up in some ways, but the question is when should you vaccinate someone after they've had COVID infection? And the CDC guidance is pretty clear. It says that individuals who have had COVID can and should be vaccinated. This includes people with long COVID. They should not be excluded. It is really all of the way we dose. So it's the primary series and the additional primary dose and booster doses. You really don't need to look for underlying infection and or an immune response. We know that the antibodies are still not really the most effective way to look overall. People are doing it, but it's unclear exactly what it means. How long after the illness? And I think the bottom bullet's the one that's probably the most important, which is the optimal timing is still not, there isn't sufficient guidance. So what should you really do? What do you really recommend? If it's a primary series, as soon as they're over and out of their isolation is what's recommended. I think if you're looking at a booster, or you're looking in between 1 and 2, you probably with 1 and 2, you want to complete that series. The booster probably can can drag out a little bit, because the other thing we know is that a natural infection on top of vaccine, or vaccine on top of natural infection, gives really strong immune boosting responses. I think it's, to me, the best answer to that is to do it in the way that is most convenient and effective for the individual at the time. But it should be probably before 3 months after the vaccine series. USC, what do we got? This is monoclonals. So if somebody has had monoclonals, there's a nuance to this now. It used to be, we sort of all learned it was 90 days after monoclonal administration that we should wait before we vaccinate. The timing varies for the indication. So if it's for post-exposure prophylaxis, the vaccination can occur 30 days after. Again, if it's for treatment, it's 90 days. I think the important thing is, if you happen to give it shorter than the recommended deferral period, you don't need to go back and repeat the dose. It's still most likely going to be effective. This is as many things, this is a conservative recommendation based on best data at the time, and we may see this begin to, it may change over time as we get more information.
Hey, Steve, Lisa, to chime in here. I just wanted to make one observation and one question. Do you know what the clinical logic or the data is about that difference? Because that's a new recommendation, the difference of 30 days after COVID. What's the clinical biologic basis?
And I think, and I don't know 100%, so I'm going to be careful in what I say, but I suspect it has to do more with host and exposure period, but I really don't know. I couldn't figure out a biological, but I did see the recommendation, heard it discussed. So if somebody else knows, I'd be happy to be educated on that, because I couldn't logic it out myself.
The other thing, if somebody has a thought, feel free to chime in. The other thing I just wanted to point out is, I think clinicians maybe are conflating this, what was a straight 90-day, now is 30 versus 90, whatever, but that 90-day deferral with natural infection, because I hear that all the time. I get so many questions from clinicians and peers about, I was told, I have a patient, or from individuals, from just friends or family members, I was told I needed to wait 90 days after an acute COVID infection to get a vaccination. And I fear that these two things are getting conflated.
Yeah, I agree, because I think the other thing that's wrapped up in there is, if you look at how the CDC categorizes cases or follows somebody, we generally recommend that you don't need to test somebody unless symptomatic
Yeah.
within 90 days. And
Yeah.
and that was based on the early information that suggested after 90 days reinfection could occur. It did not seem to be occurring in the first 90 days. And I agree that it's like they do all seem to roll together, but there are different reasons for each one of those periods.
Yeah. Okay. I'm gonna keep going here.
So I'm going to turn this one over to Amy.
Thank you, Steve. So we're all very excited that the FDA authorized the Pfizer vaccine for the 5 to 11-year-olds last week. We think, based on the census data, there's approximately 96,000 children in this age group in Maine. And there's been a lot of work to get the vaccine clinics up and running and start vaccinating kids. The vaccine was found to be 91% effective in this age group, which is good news. As most of you know, it's also a third of the dose of the adult Pfizer dose. So it's coming as a reduced dose and different packaging, which we'll talk about in a minute. Same as the adults, you're getting a 2-dose series, 21 days apart. And the Maine immunizations program has been releasing a lot of information the past week, probably every day or every other day. They're releasing guidance. A few weeks ago, they released guidance on availability and ordering through the impact system. And they continue, as of last night, they were still putting out clinical guidance and updated standing orders. So if you're an immunization program provider, you should be checking their emails frequently coming off the listserv. Same active ingredients as the adult vaccine, just a lower dose. We get a lot of questions about, if you have a child who is tall or big, should they get the adult dose? But it's really based on their age and on their immune response, not on their size or their weight. So for example, if a child is 11, they would 11 3/4, they would still get the dose for the 11-year-olds. If a child turns 12 in between doses, they would then go up to the adult dose, the 12-year-old and up dose. I think when you're talking with families, we should lead from a safety standpoint, just showing that the clinical trials have shown that these vaccines are safe and effective. And there are some side effects, but they're similar to the adult side effect profile: sore arm, fever, maybe fatigued, and usually they go away in a few days. Very rare cases of myocarditis have been reported in the older age group, the 12 to 17-year-olds. I do not think that there have been any cases with the Pfizer vaccine in the younger group, and reactions are also very rare. We're also talking to clinicians that they can get their flu vaccine and childhood vaccines at the same time if that is available, and that it's recommended for all, just as Steve was saying, even if they've had a prior natural COVID-19 infection. Go to the next slide, Lisa. The state is working with many of you, with the vaccine providers, around making sure that the vaccine is accessible. One of the first priorities is to get the school vaccine clinics up and running. It's similar to the H1N1 and flu vaccine plans. As of yesterday, I think there was about 115 school vaccine clinics already scheduled, and they continue to be scheduled at a pretty rapid pace. What's happening is the Department of Education has a public health response team. They're working with the different superintendent regions and the schools, and they are working with the schools to make sure that they have a partner on the vaccine provider side to be able to provide vaccines. So we know in the next several weeks, there will be vaccine clinics at the schools. We're really trying to encourage families to go to the schools as one of the first options to try to get a lot of children vaccinated quickly. There will also be community clinics, the retail pharmacies. What we understand is Walgreens is scheduling, Hannaford's and Walmart are also scheduling right now. CVS is coming online, hopefully in the next few weeks. There are some EMS providers, especially down in York County and some other areas of the state, who are very actively scheduling clinics. And some of the medical practices and hospital clinics are also scheduling vaccines. There is the pop-up clinic option. If you have a school that doesn't have a vaccine clinic scheduled, or you're looking for a community clinic, you can go through that way through the link with the Maine immunizations program to try to match with a vaccine provider. But they are trying to coordinate this with the public health district liaisons and with the Department of Education's work with just to make sure that we're utilizing our resources as efficiently and effectively as possible. And part of that is just the need for staffing support for these clinics. And Department of Education does have their school located vaccine clinic updated their toolkit. You'll see on this chart from the federal CDC, it just highlights that this is packaged in a different color container with an orange top. It's a third of the dose. And currently the boosters are not recommended for this age group. So this chart comes from the federal CDC. You can go to the next slide. Yep. So this morning, they just actually updated this chart for the COVID-19 vaccine. So there's been approximately 2,000 doses for this age group that have been delivered in the past several days. And this information is going to continually be updated. It gets updated each morning around COVID-19 vaccine rates for all of the ages. And you may know that there is also a separate dashboard that does it by school SAUs, and that will be updated in the coming month. There's not enough data right now, and around the 2-dose series, it's going to take a little while for that dashboard to be updated, but this one has been updated as of this morning. There is a community forum. You may have seen it. I saw it on the news this morning around pediatricians from the different health systems. We'll be doing a virtual forum tonight at 6 o'clock, and that is open to the public. They'll be taking questions. And the other piece is that Department of Health and Human Services and Department of Education do have a video contest around childhood vaccines for the youth to submit their videos by November 22nd. And there is a cash prize for the schools that the children are from with a $50,000 first place if they are selected. There is lots of information coming out nationally from the National AAP on COVID vaccines, and Lisa has these all on the slides. A lot of material coming out from the federal CDC as well. So there's just a lot of information coming out since these vaccines had the emergency use authorization. You can go to the next slide. The other thing is that we just want to continue to remind people that the US CDC recommends urgent action to increase COVID-19 vaccination amongst pregnant people. Nationally, it's estimated only 25% of pregnant people are currently vaccinated. We have had some fairly challenging outcomes from women who are pregnant who have gotten COVID-19 and gotten very sick in the state. So we are really encouraging people who are pregnant postpartum to get vaccinated. There are the 2 ads on the TV around women and children around vaccines. And in the next 24 hours, Maine Care is also going to release a nice information sheet that will be translated around childhood vaccines, as well as the Maine CDC also has a more colorful information sheet for families that they're going to be putting out as well to help guide these conversations. So I think, Lisa, that is it. I'll turn it back over to you.
Okay, so why don't I stop here to talk about questions related to the vaccine, and then I'm going to go into a little bit more about monoclonal antibodies, but since it's a whole different topic, why don't we pause for any questions? I haven't been able to see chat because I've been sharing screen, but
I don't see any questions yet, Lisa.
Yeah, or anybody, feel free to unmute, ask questions. Anything? No? Okay, there we go. Can a 16-year-old receive the booster?
It's currently the boosters are for 18 and up.
And I think that's FDA authorization, correct?
Mm-hmm.
Yeah. Okay. Others? What about an immunocompromised 16-year-old?
I think they fall into the other category around immunocompromised, Chris.
And does that go as low as 16?
I think it goes as low as 12, but I'll double check.
And again, that's that distinction about third dose for immunocompromised versus booster for others. So just an important language.
Yeah, I'm looking at the US CDC booster shot webpage that I'll paste in right now. And from there, it's eligibility for booster is 65 or older, 18 plus who live in long-term care, 18 plus with underlying medical conditions, and 18 plus who work or live in high-risk settings. So that would not include anyone who's 16.
But I think the distinction Amy was just making, Isaac, would be, does it fall under the, so you're reading the booster info, which is 18, but if they're
Yeah.
immunocompromised, does that go lower?
Yeah, it's 12 and up for immunocompromised.
Okay.
So the ICF resident, no, 16,
Yeah.
but immunocompromised, younger to 12, yes.
Yeah.
Thanks, Amy.
All right, and there's a question about fluvoxamine as treatment. So I'm gonna hold on that one until we talk about the other treatment issues. Any other immunization vaccine questions? Okay, then I'm gonna go back to shift gears a bit and talk about treatment. So what's out there now and what's coming? So Amy, can you see my slide again? Put it back. Anybody?
Yep.
Okay. So monoclonal antibodies have been out for a while in terms of treatment of COVID-19, but what's changed in mid-September was that while providers who wanted to offer monoclonal antibody therapy could previously order directly from the feds, as of mid-September, because of the ongoing Delta surge and rapid increase in therapies, particularly in administration by a subset of states that were using up essentially 70% or more of all the available therapies, they changed that to make states responsible for allocating monoclonal antibody therapies in their state. And they, the feds, made decisions on allocating doses to states to make it more fair, so they didn't get all used up by a small set of states. So the U.S. government now determines the weekly distribution for each state, and starting in mid-September, we then determine the allocation to providers, and we've been getting about 500 to 700 doses a week. So while initially that was a lot less than what had been ordered, we also, or because of that, we made the recommendation that these three therapies, and see, similar to my little vaccine slide, just the three. So the Vaccinate for short, Regenco for short, because I'm not going to attempt to say the names, and Sotrovimab as the newest addition to that fleet of monoclonals. Are available, all have similar FDA authorization for treatment of individuals with mild to moderate disease, all for adults and children greater than 12 who weigh more than 40 kilograms, any individual who's at risk for progression to severe disease, which includes a whole list of conditions. Initially, Vaccinate was found to be less effective against the beta and gamma variants, but has found to be effective against Delta. So it was paused for a while in terms of use, but then reauthorized again, or approved, whatever, authorized for use with the Delta variant. Regenco is the only one that can be given right now through SubQ injection, though IV is stated still preferred, but because of staffing issues, and the data, I think, Steve, you could speak to this in a minute here. Really, there's not a lot of data about a whole lot of difference between IV and SubQ infusion. So if it's a matter of no treatment because of staff shortages versus SubQ, we've been encouraging sites to consider SubQ administration. Because of that limited supply, we've asked provider sites to prioritize monoclonal antibody treatment for individuals diagnosed with COVID, and then for post-exposure prophylaxis, specifically in high-risk congregate settings, specifically long-term care and correctional institutions, meaning not to routinely offer post-exposure prophylaxis for other individuals in non-high-risk settings, just again, because of limited supply. And then within that, certainly focusing on individuals at high risk for developing severe COVID, which again is this long list of conditions, including age greater than 65, overweight or obesity, pregnancy, et cetera. So it really could be quite a few individuals. And we initially have encouraged priority to those who are unvaccinated, primarily, again, because of this risk of developing severe disease, as well as vaccinated who are not expected to mount an immune response. really with the overarching goal of trying to preserve hospital and ICU capacity in the state by preventing progression to severe disease, given what we know continues to be relatively high case rates and quite high rates of hospitalization, ICU, and ventilator use in the state. So again, we're not trying to deny treatment, from certain individuals. And we've heard, well, people are good enough to get vaccinated, you're denying treatment. No, we're trying to aim this limited resource to individuals who are at most risk for developing severe disease and stressing our hospital and ICU capacity because they're more likely to develop severe disease. We also know certainly trying to encourage use in those areas of the state, such as the rural areas that are still plagued by high unvaccinated, high rates of low vaccination, unvaccinated rates, and so trying to just make the biggest impact that we can. With that said, then the question is, well, who's available to do it? We have 40 Maine sites that are registered, and you have to register with the federal government to receive monoclonal antibody doses. That includes, you can see here, 21 hospitals, 6 specialty pharmacy or infusion providers, 4 of which are the long-term care providers, 6 of the convenient MD urgent care centers, 5 primary care, 3 of which are FQHCs, and 2 correction sites. And of those, 32 sites, and I've got a hyperlink there, that take referrals from providers or the public, meaning that like the long-term care specialty pharmacies are not taking direct referrals from providers, or the jails are not taking direct referrals. And then some sites and some hospitals have said, we just don't have enough, particularly staffing capacity, to take direct referrals. We're taking referrals from our emergency department and we can't really do more than that. So you can see here my own little rough sketch of where they're located, which is quite widely across the state. There's also a website run by the National Infusion Center of America that you can put in a zip code. We've encouraged our sites to make sure their information is posted here and is accurate. It goes again by zip code, so you can see just a screenshot here. I will say it is not 100% accurate. We continue to encourage providers. And it's between that and the link that I have in the slides, we've created a list of those 32 sites where providers can send people, knowing that if we're going to try to encourage providers to identify people at high risk and refer, we need to let them know where they can send folks. So we know that we're still having case rates of between 500 and routinely 600-700 cases of COVID a day statewide that are reported, recognizing it's probably more than that. Not everybody within that falls in the subset of high risk for progressing to severe disease. A lot of them are children, certainly, who might not have underlying conditions, but probably a fair number are. So if you take that number and say, how many might be candidates, I would guess it's probably at least several thousand, and yet we're only getting orders from our monoclonal antibody providers of less than actually our full allocated amount. We're getting orders of about 300 to 400 doses a week. We recognize that, again, a huge amount of that limitation is workforce limitation. The IV infusion takes an hour, and then they have to be observed for an hour. SubQ is faster, but they still have to be observed for an hour, and they have COVID in most cases, unless, again, it's the post-exposure prophylaxis in high-risk settings. So all kinds of issues, but we are just trying to promote awareness. We sent out a fact sheet through the professional associations about a week ago that includes, or supposed to include, a link to that set of 32 providers, and trying to promote awareness of that national treatment locator site as well. So I think we still have some work to do in terms of getting the word out. Would certainly urge all of you to be communicating within your communities the availability of this treatment, because it really can make a big difference in terms of helping to decrease the likelihood that people will progress to severe disease. And I've been talking only about the monoclonals in an outpatient setting that's specifically for people who are not hospitalized. There's another one that's used in the hospital setting, but seems less relevant for this audience. So that's monoclonals. And then I'm going to invite Isaac to talk about the newest development coming our way in terms of oral antiviral drugs, or a new acronym, AVDs. Isaac?
Thanks. So there are a number of oral antivirals that are being studied, and there is one that's very close in the pipeline that we're hoping will be available within the next even 3 to 4 weeks. So this is molnupiravir. It's an oral antiviral specifically targeted at COVID-19. It's a 5-day treatment course that's supposed to be given starting within the first 5 days of symptom onset. The initial data are really robust and suggest roughly a 50% decrease in hospitalization or death for patients with mild to moderate COVID-19. We are still working with federal partners to sort of understand a number of the parameters around sort of how to make sure this is targeted best. It will require a confirmed COVID-19 test, which certainly represents one barrier. The other constraint that we're aware of is that it was not studied in pregnant patients, and so it won't be administered to anyone who's pregnant, also representing a hurdle because patients will likely need to see a provider if they're female and in an age group where that is a concern. We expect to learn more in the next few weeks regarding the amount that we will initially be allocated and when that will show up. We're working to determine the best places to position this, and there are still a number of, frankly, unanswered questions with regards to how the availability of this and the availability of monoclonals overlaps, and whether patients would receive one or the other depending on timing, whether any patients would receive both, exactly which patients to prioritize in each of those timeframes. So really more questions than answers, but hopefully more coming soon and an exciting development.
Great. So with that, I'm going to stop sharing. Just a reminder, we are holding these sessions still monthly. So the next one would be December 14th, include the links, and we will again post this slide set that has all the live links with the recording to the Maine CDC website where we normally go post those. So I see a couple of questions coming in.
One is, what are the thoughts about the use of Fluvoxamine as a treatment for COVID? Some patients are asking.
Yeah, there were studies about 9 months ago, or maybe even longer, that were small, that showed some potential benefit. There have now been larger randomized trials which do show that there may well be benefit. Remember, fluvoxamine is a drug used for OCD. It's been around for a long time. The side effect profile is well known. So there's some excitement around this, but the data really is not that strong yet. And there is not recommendations from, I believe, NIH or some of the other major guidance providers. But it's something to really watch out for. I think it's, I think we'll see more. There's one study, and that's, we've learned a lot about the history of COVID in one studies. There really needs to be a little bit more information because we clearly don't know enough yet. But it's, as I said, it's coming along, and we'll see.
What are your thoughts about selenium supplementation, 100 micrograms a day for improved resilience against serious viral and bacterial infections, including COVID-19?
Well, anybody else who wants to try to answer that too, because I'm going to sound like I'm talking about fluvoxamine, which is that there's some really small studies that suggest there might be benefit, but they're just that. Selenium deficiency is known to be associated with poor outcomes. So would selenium as a routine amount, and I really can't speak to 100 micrograms per day. I know that from the NCBI there was a study that suggested there might be benefit from selenium, but it's not an antiviral. It's really an antioxidant and perhaps a immune system booster. So I've not seen a significant study of that's either double blind and or of a large enough number to be able to know what to do with this at the moment, but it is being looked at pretty carefully at this time, and I don't know if anybody else knows.
Nope.
Hello. This is
Hi, yeah, go ahead.
Yeah, this is Elizabeth Dragazzi. I'm a pharmacist specialist in pharmacotherapy, and this came to my attention, and it's been corroborated from a strange source in the state of Maine through the veterinarian who is in charge of animal feeds in the state states that there is a shortage of selenium in the soil of Maine, New Hampshire, and Vermont because the bedrock is granite. And he was a strong advocate of supplementation. They have recommended it to be in all the animal feeds to minimize the use of antibiotics. And he did indicate that there was antiviral benefit in the in the herd community. No pun intended. I am inclined to think that that would be a useful supplement for those who live in New Hampshire, Maine, and Vermont in the COVID context. I don't think I agree with you, there are no randomized controlled studies, but for those who are not opting to take vaccines for one reason or another, I have recommended that to them, at least as a measure they can take to give them a better chance to face the COVID insult.
Yeah, and thank you for that. From my perspective, would still like to see more data. And I can't actually speak to whether there's selenium, a lack of selenium in the soil in Maine, and whether that actually translates into anything that has to do with human disease. It might well have more if that being true for animals that are eating all the stuff growing from our soil. But interesting, as I said, I think that one has to look at the last year and a half at a multitude of different deficiencies and or supplementations that have been both identified and or suggested as supplementation, in vitamin D being one of the ones that was used a lot. And just be careful with what we know and don't know, and try to follow the literature to add something. Is selenium causing a problem? No, unless people start taking things in excess, which is unfortunately what we have seen with almost every COVID drug, which is the potential for real overuse. It has been borne out with a number of different compounds that we wouldn't have thought. So more to come on this one.
Okay, then I'm seeing one more. Do you anticipate using a framework or workflow similar to accessing monoclonal antibody for accessing orals, such as molnupiravir? Isaac, putting that back to you. Isaac's in charge of this one.
Yeah, well, Lisa, you know more than I do about the sort of framework and workflow that we use for monoclonals. So I'll say a little bit, and then invite you to add on. I think we're certainly hoping to be somewhat clear in terms of clinical criteria, in terms of which patients and what presenting symptoms would be appropriate. It's in some ways it's going to be a bit more straightforward than monoclonals because it doesn't require an infusion, and so it's just an oral drug that we'll be able to position at pharmacies and likely other settings. And so there will still be sort of a clinical threshold for being evaluated prior to administration or dispensing, but the delivery is going to be a bit more straightforward. Lisa, what would you add to that from your monoclonal side?
Yeah, so the one thing, if I were a magician, if I were in charge of the world, right, I'm clearly I'm not, would be to really get clinicians thinking up front when testing is ordered about whether somebody is at high risk for developing severe disease. If we had a way to, whether through clinician office, I mean, ideally on a lab ordering form, but it's going to take quite a bit at this point to identify. I mean, there are so many of those conditions, right? 65 and over, diabetes, hypertension, overweight, obesity, to somehow be flagging up front within the clinical workflow that if a positive comes back, this person is a candidate, to sort of trigger that, up front for either monoclonals or molnupiravir. And as Isaac said, it's not entirely clear yet, is one going to be better for somebody than something else. So would really be urging clinicians to be thinking about that within your own practice settings too, because of that time limitation, right? At least with monoclonals, it's within 10 days. This is within 5 days of symptom onset. It just makes your head almost explode, right? Thinking about trying to get within that time window. So I think we'll certainly be doing everything we can. We're going to try to learn from other states, what they're doing in terms of getting thinking frameworks, workflows to help clinicians and patients take advantage of those therapies as much as possible.
Yeah, I mean, I saw the follow-up question as well regarding, thinking about how to prevent runs on molnupiravir and shortages. And, this is an imperfect world. We're going to get some initial allocation. It will almost certainly be less than the number of people who want the drug. We simply don't have the luxury to, wait for a 2-week snapshot and decide which patients should have received it. We'll, set eligibility criteria, and if a patient comes in who meets those, I think we're going to have to be able to give the drug to patients who meet it without waiting to see whether someone with, more severe symptoms comes in 3 days later.
And I invite Cheryl. So Cheryl is also an epidemiologist, Isaac, from the Mid-Coast Penn Bay area. Cheryl, I see you're unmuted. I'd love to hear your thoughts on this.
Yeah, I do have some thoughts because, we've certainly been thinking about this for several weeks now. We're one of the largest providers of monoclonal antibody therapy in the state, I believe. And we would really like to be able to build on our current workflow for monoclonals in terms of molnupiravir. So it seems to me that, we've been through this before, right? We've been through this entire process with the exception of the need for an infusion center. So when monoclonals first became available, they also needed to be given within 5 days. And that was much harder with monoclonals than it's going to be with molnupiravir. And in any case, we now have a system where if a provider has a patient who they think is a candidate for monoclonals, they basically make a very simple referral in our electronic medical record. And then our monoclonal infusion center staff handle that referral very quickly, very efficiently, and identify whether that person is actually a candidate, and then work on scheduling, which is of course, much harder with monoclonals than with an oral drug. So it just, and I think it's fair to be pretty confident that the initial criteria for access to molnupiravir is going to be very similar, if not almost exactly the same as it was initially to monoclonals. So understanding that, I'm wondering whether a good way to think about this is basically to identify designated prescribers or designated center prescribers up front, rather than try to get every clinician to, to follow the same set of guidance. We did not attempt to do that with monoclonals, and I think that was smart. We would not have been successful, I don't think. So I'm just throwing out there that at least here, we're thinking a lot about how we could actually just use the exact same workflow that we have for monoclonals, obviously adapt it if there are differences in criteria, but use that in terms of centralizing who's prescribing these drugs and who's kind of making the final call on eligibility, because it's sort of easier to hurt a smaller group of cats than a larger one.
Yeah, it's a great point. And I think, what you have, the beauty of having there, Cheryl, is a center, right? That you have an identified place where you made it easy for providers to refer to the place, and then the place sort of decides and takes over. And we have some of that, but not, not what I would call sort of a smooth or a standard system statewide. You saw the list where we've got infusion sites in 21, but not 33 hospitals. And some, that's partly because some hospitals refer to other hospitals, including, some in your region, but partly in some areas of the state, we just don't have that. And then we have, other kinds of providers, but it's not, it's an interesting question. Could we somehow sort of crystallize what we have now in terms of infusion providers into more of evaluation treatment providers? But it's a challenging task because they are not, one does not all look like the other one,
Yeah, and our biggest, and we had to limit them, as you guys pointed out earlier, we had to limit the number of referrals we could take from outside sites, mostly because of just like the manpower issues with infusions. But you're not going to have those issues with this. And I wonder whether, again, it'll be easier it would be easier to set up more centers, or for, the state or whoever to assist some of the smaller hospitals in identifying like a point person in each region who could be kind of the resource to manage, ensuring that those who end up with prescriptions for molnupiravir are the right candidates.
Mm-hmm.
Just an interesting thing to start thinking about it seems.
Yeah, and as always, right, anytime something is complicated, it's more likely to hit the vulnerable populations harder, right, to be disparate. And those with more resources and more connections and more knowledge are more likely to get the thing than the less resourced,
Yeah.
right? So also thinking about that.
Right. And there's also, like, in the non-COVID world, there are the ECHO projects. Steve Sears is probably familiar with this. So these are the projects to do things like be more equitable and provide more comprehensive access to hepatitis C treatment. So applying that kind of model to this, might also be an interesting opportunity, because, this can be done virtually pretty easily.
Yeah, and use of learning programs like ECHO is a great idea. So some great thoughts. And again, Isaac is leading this process for us, and we've got a few weeks to try to figure it out. I'm sure it won't be perfect, but really appreciate folks' input and thoughts about that as we continue to develop the strategy.
Yeah, and there are probably another several antivirals that are coming out down the pike after molnupiravir. Pfizer has a drug called Paxlovid, which is probably 3 weeks behind. And so it's going to, we will have to try to get this figured out.
And AstraZeneca, another one, right? Or is that the
AstraZeneca is the
long-acting
long-acting monoclonal, but there are several other drugs that are in the pipeline. And a lot of this is, there's been two major directions for antiviral or therapies. And, one, when we think about selenium and fluvoxamine, there are looking at repurposed drugs, ones that were already available, already approved, as opposed to then drug development, which is where molnupiravir has come from. It actually was originally developed as an anti-influenza drug. There are several others coming down very soon after that that look promising. And again, all of these, we just haven't seen all the data yet.
Okay, and then I see a comment from Elizabeth Dragazzi again about concerns about fluvoxamine for COVID and potential mental health concerns. And I think we are trying to be very clear here. We are not recommending that. It was, a comment that was made about another drug being studied. So to be clear, right, that's not something we are endorsing right now by any stretch, at least until more data comes out. Other questions? Okay, well, we appreciate your efforts to join us today. Again, we will post the recording and the slides to the Maine CDC website, and appreciate everybody's help with continued efforts to fight this pandemic, which will end at some point, even though it feels like it won't. Okay, thanks everybody. We'll plan to be back in December with probably some more updates. Thank you. Bye-bye.